Good morning, everyone, or should I say good afternoon because it's 12 now. Welcome. My name is Dr. Laura Pilgrim, and I am your host for today. And you will see Miss Althea Gittins online as well. She's your co-host. So we're just going to jump right in and get started. So I'm going to share my screen and then we will begin. Thank you for coming. The International School for Development Justice at UWI presents the SDGs and You, Making Connections for Progress webinar series. Starting September 17th and continuing on every third Wednesday of the month, we explore the 17 Sustainable Development Goals, what they are, their impact on Caribbean people, and the progress and challenges we face. Join us for 12 dynamic sessions with local and global experts. Ask questions, share your story, and make connections for progress. The SDGs and You webinar series. Register today. All right. Thank you for coming, everyone. We appreciate that you're here and on time. So we would like to make sure that we end on time. So we're privileged to have two speakers on SDG 3, Health and Well-Being. That's our topic for today. First, we will hear from Dr. Sandeep Maharaj and then Dr. Heather Harewood, both faculty members at the UWI. Speakers will each have 20 minutes to share with you, and then there will be 15 minutes for questions. So let's get started. I'm going to introduce Dr. Sandeep Maharaj. He's a pharmacist who is currently the director of the School of Pharmacy and director of the Entrepreneurship and Business Transformation Office for the Faculty of Medical Sciences at the UWI, St. Augustine campus. Dr. Maharaj is also the principal investigator for the Caribbean Climate Cares Project and a member of the core team of the Imperial College-led project Connecting Climate Minds. Dr. Heather Harewood is a lecturer in public health and epidemiology, a public health physician who is currently the coordinator of the Masters in Public Health, the EMBA Healthcare Management, and the UWI PAHO Postgraduate Diploma in Health Policy and Health Systems programs at the UWI Cave Hill campus in Barbados. Dr. Harewood is also the SIDS regional lead for the Working Group on Economics and Finance for the Lancet Countdown on Health and Climate Change. So we have two well-known experts with us today, and I'm going to invite Dr. Maharaj to go ahead, please.
Thank you very much, and pleasant good evening, good afternoon to all now. And I have been given the task to speak about introducing SDG 3 and good health and well-being. I am definitely humbled to be asked to do this today, and I will wish to give some of my experiences. Now, why does SDG 3 matter at the end of the day? SDG 3 actually health, and Sir Michael Marmot coined the term health in all policies, actually is one of those that cuts across almost all of the 17 SDGs. And the Caribbean region, for example, is one that is really burdened with non-communicable disease, such as diabetes, hypertension, etc., which you all know, and the emergence, due to climate change and other issues, of new infectious disease, such as dengue, Zika, chikungunya. And if you put that over the overarching issues of sepsis, which impacts on the most vulnerable and the poor, it's really a disease of the poor, and the impacts of antimicrobial resistance, which is required to deal with the outcomes of issues such as sepsis. Really and truly, the Caribbean region has a significant burden to deal with going forward. Small island developing states, when you look at it, we suffer from low issues of limited resources, geographic isolations, and I spoke earlier about climate change. And hence, strengthening our health systems is a critical imperative for ensuring justice and equity is reached across the entire region. How has the Caribbean region done when it comes to healthcare? When you look at life expectancy, the global average is around 73 years, and between 70 to 76 is when you go across countries, vulnerabilities there. Sorry, there's variability. 70 to 76 with places like Trinidad with 73, places such as Barbados with a higher life expectancy of 77. Under five, mortality has decreased by 50% as of 2000, and they are less than 20 per thousand on average in the Caribbean. However, NCDs, which is greater than 70% cause for all deaths globally, the Caribbean looks at 8 to 10, 8 out of 10 deaths, approximately 80% attributable to NCDs. So that is fine in the sense that we are meeting some global norms, but all of this happens in a very constrained and restrictive environment where we are looking at approximately the globally 9% of GDP is spent on the, healthcare, while within the Caribbean, 5 to 8. So hence we have to be cost effective, evidence-based to really maximize the health outcomes. And it's in that environment the Caribbean operates when it comes to healthcare. So when we do a deep dive, I've been asked to look at certain aspects of SDG 3. And the first one I like to delve into, which is substance abuse and prevention and treatment. Really and truly, the Caribbean has, and depend on the country, some issues when it comes, for example, to substance abuse and prevention. In Trinidad and Jamaica, one will see there's increased rise in the consumption of alcohol, especially that there's a cultural normalization when it comes to alcohol consumption. There has been cannabis reform policy, for examples, in countries such as Trinidad. Jamaica has a licensing authority. Trinidad, you're allowed to grow 4 plants, and there's a limited level of usage. While all of this is happening, there continues to be a major gap when it comes to access in rural areas for people who require these sorts of interventions for mental health, as well as basic prevention. That remains a critical issue. And even the policy that was put forward by the CARICOM Commission on Marijuana for school-based prevention that targeted young children, this really needs to be expanded, because to what extent has this been successful is something we need to look at. 3.6, which looks at road safety. Globally, Trinidad and Tobago actually and Guyana has some of the highest levels, 12 to 14 deaths per 100,000. And this can be attributed to things such as poor seatbelt use, alcohol impairment while driving, and inadequate road structure. Just recently in Trinidad, someone died driving off a road in flooded water, and they missed the entire bridge. Person died. These are the issues that we have to deal with, and hence there's a need for proper traffic law enforcement, smarter road designs, and better engineering. And at the end of the day, it has been seen as a problem where PAHO has actually the decade of action for road safety in 2021 to 2030. And let us see to what extent regional coordination and capacity building takes place here. When we look at universal access to sexual and reproductive health, again, some of these things rear its head, not in a very nice way. So, for example, in Guyana, currently it exceeds 90 out of per 100 adolescents are actually pregnant. So, adolescent pregnancy is a big issue. Contraceptive access, limited availability for modern contraception. I will go further to state period poverty is also a major problem within our schools and our school system when it comes to sexual and reproductive health. Because it's only now, recently, the Trinidad government, I can speak on, has passed a bill allowing and putting funds towards having sanitary pads and so on available for students in the schooling system. And this is something that we need to look at and look at seriously, just beyond contraceptive access. Also, what are the issues that are faced with period poverty across the region? Gender-based violence continues to have a very high level, and there have been regional responses by the UNFPA, which looked at this issue, and comprehensive sexuality education programs, community-based advocacy, and hence it continues to be a very culturally sensitive issue. Multi-sectorial collaboration is required because there continues to be persistent gaps in this region in 3.7. Now, each one of these, when I say there are gaps, it allows for research. Each one of these can be its own research topics and own mechanisms, but I will speak further than that. Universal health coverage. This continues to be something that plagues the Caribbean, not because it's not want to be done, but it really the constraints of governments when it comes to funding. For example, Trinidad has tried to expand universal coverage via also having a chronic disease assistance program. Jamaica has removed user abolition fees. Barbados, Bahamas has developed their own national health insurance plans to actually, deal with the issues when it comes to access to healthcare. However, continuous shortages of health workers, particularly in rural areas, shortages and inconsistent issues around pharmaceutical supplies and security. And we all saw this when COVID took place, how long it took for the Caribbean to even be recognized for vaccines. And this is something that is the norm when it comes to specialized drugs. Limited availability of specialized services and high out of pocket expenditure for middle income households. It is really a significant area in which we have to innovate, recreate, and look at new mechanisms to improve coverage while reducing costs and being highly effective. It is something that takes long-term planning, and it requires consistent effort to ensure delivery. When it comes to environmental health, we all know countries such as Guyana, Trinidad, Belize, Suriname, soon to be Grenada, and Jamaica all have issues when it comes to petrochemical exposures, air pollutants, occupational hazards, and respiratory disease and cancers. This is very well documented. Wastewater, and now we are going to see the massive influx of sargassum within our area. We have to be very mindful and careful in how we deal with this. But a lot of lovely innovations are coming out where sargassum is being used as energy stock, feedstock. So we require innovative response. And finally, vector expansion. Climate change, as you all know, has increased, and the temperatures and climate change. When you look at climate change, it is not getting hotter. It's just not the place getting hotter. It's a matter of the rains in season getting longer, the dry seasons, so the wet getting wetter, the dry getting drier at the end of the day. And this is what actually gives the best sorts of environment for growing up vectors and their ability to spread their diseases. And right now, Africa is looking at Rift Valley virus, which is a fever, which is another issue that we can deal with soon. Tobacco. Most Caribbean countries have the Framework Convention on Tobacco Control. This has been accepted in most of our territories. However, e-cigarettes have been pushed onto the market as a mechanism to, that doesn't carry the same harms, which more and more research is showing it is a major issue and it's a growing issue in the Caribbean. Barbados, Jamaica has shown graphic designs as part of their legislation for warnings on their stuff, while Trinidad, they have banned public smoking, and some of the countries have put taxation to reduce consumption. However, it is something not very well utilized across the Caribbean region, and more can be done there. Access to medicines and vaccines are really, really critical in any health system. And the issues, for example, the Caribbean has the PAHO revolving fund for vaccines, which assists significantly with us getting good vaccines in time. However, at the end of the day, the cost to governments for medications continue to rise. Also, one of the main issues that Caribbean region faces is investing in proper cold chain infrastructure. And many times people think that vaccines are the only thing that require cold chain. With climate change, cold change, cold chain actually, tablets need to be stored between 8 degrees to 25 degrees Celsius. 2 to 8 degrees, sorry, and 15 degrees to 25 degrees Celsius in most instances. Many times we don't have proper storage for even the 15. A lot of effort is spent on the 8 to 2. Many times we don't even have proper management of the 15 to 25. So, my dear friends, there's a lot to be done when it comes to access to medicines and how we fund and how we develop some very progressive frameworks to deal with that. Health workforce development, as you all understand, there's a significant migration of health professionals abroad, especially our nurses. We have a very aging workforce here in the Caribbean, and in many instances, the gaps really lie in the specialist areas: midwives, mental health professionals, clinical pharmacists. These are the areas that actually make us suffer. So, at the end of the day, we need to expand training, look at different licensure mechanisms to keep persons. And Guyana has a very, very innovative way in their new rural health centers. What they are doing, they already have telemedicine taking place there. So, what they have started is virtual learning in those health centers as well. So, persons use the health centers both as a place for learning as well as a place and space for healthcare delivery. So, when we look at SDG 3, health and equity for SIDS, climate change must be addressed. Number 2, we need to strengthen our data systems. We need to integrate basically our efforts for AMR and sepsis in our SDG reporting. And most importantly, strengthen our partnerships when it comes to academia, civil society, faith-based organization, and international agencies to ensure basically we have a significant impact when it comes to SDG 3. I will skip this case study on Trinidad and Tobago, and I will go on to my final slide just to let persons know. Health is not just the absence of disease. Health is actually the presence of justice, equity, and resilience. The Caribbean is a microcosm of the global health challenges and solutions, a region where innovation meets adversity and where solidarity confronts scarcity and where hope persists despite vulnerability, my dear friends. Sometimes I may have painted a grim picture, but I wish each and every one know at the end of the day, in the Caribbean, we act and we operate within a system where we innovate, have significant solidarity, and our hope for a better day helps the system push things forward. Just to finish, the time for action is now. A healthier Caribbean by 2030 is possible. if we choose solidarity over fragmentation, equity over exclusion, and resilience over hope. Thank you all very much as I pass on to my next very capable presenter, Dr. Heather Harewood.
Thank you so much, Dr. Maharaj. And yes, Dr. Harewood, please do go ahead.
Thank you very much, Dr. Pilgrim and Dr. Maharaj, for the introduction. And I want to thank the organizers for this opportunity to be able to be a participant in this seminar. I just want to say there's no conflicts of interest, and I'm so grateful for the platform which my colleague Dr. Maharaj set in terms of defining health, because one of the things as a public health practitioner, I always like to, set as a framework is that we're looking at health in the broadest term, not merely the absence of disease. We look at health as a resource for living. We look at health as the opportunity to achieve the three components that were just described, where there's justice, there's resilience, and there's the ability for people to really have equity in their lives and to obtain the SDGs, which is why we're here today. So my task is to speak to some specific SDG targets, and I'll be reviewing targets 3.1 to 3.4. And I will be trying to draw the link of the interrelatedness, a theme, if nothing else you take away from here is the interrelatedness between these targets. And as was stated earlier, health really underpins a lot of the SDGs, and similarly, a lot of the other SDGs impact on the ability to achieve and maintain a good quality of health. We'll look at some of the context with respect to small island developing states, look at some progress and achievements, look at challenges, but always trying to end on a very positive note. What are the areas that we need to focus on going forward, and what are the opportunities? So SDG 3 speaks to ensure healthy lives and promote well-being for all at all ages. And this underpins the whole life course approach to health and living and well-being. And the targets here, as you can tell from the infographics, will relate to maternal health, looking at children under 5 mortality, but there will also be a bit about the neonatal mortality. Target 3.3 looks at infectious diseases, and target 3.4 looks at NCDs, and something which we all know is very important in our region in terms of the burgeoning numbers, but against the backdrop of persistent and endemic levels of certain types of diseases such as dengue fever. So we do have a double whammy or even a triple whammy of things to deal with in our region. So maternal health, by definition, speaks to the health of women during pre-pregnancy, pregnancy, childbirth, and postpartum. Classically, the postpartum period was described as the first 6 weeks after delivery, but some of the more modern texts have actually expanded that. Some people consider up to 6 months post-delivery. But it's making the point that we need to think of women's health across the lifespan, and pre-pregnancy is very important. It is argued that women's health is really the underpinning for the society because women give birth. And there's a quote from the WHO that says that women who remain healthy during pregnancy and after birth are more likely to stay healthy later in life and have better birth outcomes. So women's health will influence infancy, childhood, adulthood of their offspring, but certainly would would influence their ability to have a healthy pregnancy and a safe delivery. So it's important to think about this across a spectrum. So if you want to look at a couple of statistics related to the maternal mortality and what the targets say. Ideally, by 2023, across the globe, it is anticipated that the target of reducing maternal mortality to fewer than 70 deaths of women per 100,000 live births, that is the target that we're working towards. Now, it is important to bear in mind that the maternal deaths are counted if this occurs during pregnancy, whether or not it is a pregnancy in the uterus. So someone who has an ectopic pregnancy would still be counted as a maternal death, and up to the end of the postpartum period. So everything that occurs during pregnancy and within the postpartum period will be counted as maternal deaths. And this underscores the point that surveillance and actually documenting the deaths and having good registry systems underpins the ability to really track this indicator or this target, because we need to identify the point at which deaths occur. Now, there's an increased likelihood of some of the things that were even mentioned in the previous presentation, because in the postpartum period, for example, women do experience increased levels of personal violence, so intimate partner violence, for example. And there's also noted that if you had to break down the deaths, maternal deaths between pregnancy and postpartum, more occur within the postpartum period. So this is actually a very vulnerable period for women, and it has implications for the health and well-being of their offspring, because you can think about, the whole idea of women giving birth. We want women to breastfeed. We tout the target of exclusive breastfeeding for at least 6 months in order to give the baby the best start in life. So we can understand why it is important for us to try to reduce mortality, because the illness or the morbidity that leads us up to mortality really does shape the outcomes for women after. And the level of maternal mortality actually gives an index or an indication of the quality of the healthcare systems. So if we look at global progress in maternal mortality ratio, I'll say MMR from this point on, not to be confused with the vaccine, we would see that, if we look at the trends between 2000 to 2023, across the various regions, there has been a reduction in the MMR levels. There are some regions, though, that are doing a lot better than others. So if we look at the low bars here, we see Europe, Western Europe, where the deaths are actually in the single digits. But yet we know there are many regions in the world, such as Sub-Saharan Africa, where still hundreds of women die per 100,000 live births of babies. So this is an important statistic to bear in mind. If we look at ourselves in the Latin America and Caribbean region, while our numbers are not as high, say, as in Sub-Saharan Africa, there's still some concern, because we would like to actually improve. So even if it is already less than 70%, we would like to see constant improvement. But there's a concern about stagnation of these numbers for a number of reasons. And this is an area that really does require us to think, how do we look at other measures, which is the third bullet I have here. What are the implications for us as SIDS? So we're doing relatively well, but there's always the opportunity to want to optimize the healthcare that has provided for men. As was mentioned, the healthcare workforce is important, so we need to have trained birth assistants. They don't have to be obstetricians, because there's the school of thought, if we look at risk-based management of pregnancy, that well-trained GPs, midwives, and so forth can offer care for women who are low risk, and their outcomes will not be any less optimal than women who would have gone to a specialist. So ideally, the women who are more at risk are the ones who should be funneled into the specialist care. And you will find that in countries where the MMR is high, there is that disproportionate lack of healthcare specialists for women who are pregnant and have complications. The other point I have here about other measures is that even though we might have a relatively low number within the region, it is important to think about what are the pathways that get women towards maternal mortality, hypertension, in particular preeclampsia, and other hypertensive disorders of disease, of pregnancy, sorry, are high among the causes for maternal mortality ratio. So maternal near miss mortality, i.e. how many women become hypertensive or have some other complication but does not lead to death, is still an important factor for us to measure, because it allows us then to tweak our systems to improve healthcare for women. So why are women dying? It could be from direct causes, which really result from obstetric complications in the pregnancy, such as hemorrhage. It could be an error in treatment, or it could be from an infection that arises due to improper procedures. It can be for indirect reasons, such as women who have pre-existing conditions that actually are exacerbated by the pregnancy state. So some women might be suffering from hypertension prior to becoming pregnant. And in some countries where MMR is high, underlying conditions such as cardiovascular disease and malaria are actually the precipitants that lead onto maternal deaths. Importantly, it is noted that these deaths, a lot of them are preventable. So that is why it is really a focus in terms of optimizing care, identifying women who may be at risk, and actually applying a risk-based approach to antenatal care. So this was introduced, for example, in Barbados over a decade ago. And the whole idea is that women who meet the criteria, whether it's from maternal factors, if they have a prior larger gestational age baby, whatever the criteria that allows them to be classified as high risk, they are seen early in the pregnancy, and the specialist is involved in their care from early. So that's one of the reasons why we speak about health system strengthening, because we can think about strengthening the referral mechanisms. We can think about training our healthcare workers to be able to identify and to refer and to treat appropriately. But remember that the health system also involves the users of the system. So our clients can be trained, they can be taught to recognize the signs and symptoms that would imply that there is a potential obstetric emergency. And at the upstream level, addressing the social determinants of health, because we know people's living conditions, their education level, and so forth. These factors determine how people understand and perceive their illness, how they may respond, and the extent to which they may seek care at all or seek it in a timely manner. Target 3.1 looks at neonatal and child mortality. Now, neonates are infants who are up to 28 days old, and children, we're looking up to age 5. And we might ask ourselves, why are infants and children dying? Now, the diagram that I have here is coming from UNICEF, which looks at the projected year to achieve these SDG targets in the neonatal and under 5. So the darker green is Latin America and the Caribbean. And, it is good to know that some of our countries have actually met the target for under 5. So Trinidad and Tobago, for example, was projected to have met that target in 2023, Guyana in 2024. But then there are some others higher up on the chart, such as Dominican Republic and Haiti, which have dates of 2041 and 2051 respectively. But we know that the conditions in Haiti, the escalation of violence and so forth, will actually make it very difficult to achieve these goals. And importantly, a lot of this is preventable because it requires good antenatal care. It requires good child care. It requires specialized services, sometimes for babies that might need neonatal intensive management, but also having, appropriate birth attendance, being able to start breastfeeding as soon as delivery occurs. So how do countries put in practice the baby-friendly hospital initiative? Some of these are very important factors. And also how to minimize the risk of infectious diseases. So vaccine preventable programs, which we may take for granted in the region because our level of vaccine preventable diseases is relatively low. But, we are getting more people who are, I would say, vaccine hesitant. And this is something that we need to bear in mind because it can really undermine a lot of the gains that we have achieved over the past few decades, because we don't want our infants to be vulnerable to vaccine preventable diseases, for example. So solutions include, as I said, strengthening the health system, addressing social determinants. So diarrheal diseases, respiratory diseases are affected and by living conditions, so overcramped conditions, overcrowded conditions, for example, lack of access to potable water or sufficient water to undertake routine hygiene practices can actually contribute to diarrheal diseases. So again, government's investment in what we would consider to be important social services or public goods really underpins the ability to achieve these goals. Target 3.3 looks at infectious diseases, and the target is that by 2023, we will end epidemics of AIDS, tuberculosis, malaria, and neglected tropical diseases. No, we know that we've made great strides in the region regarding HIV. There are a number of initiatives, such as in preventing mother-to-child transmission of HIV, where women, particularly in the public sector, are screened for HIV. If women are found to be positive, they're given antiretrovirals. They and the fetus are monitored, the baby is monitored after delivery. And this has really, brought us great success in the region. And also government seeing HIV as a priority and setting up specific treatment pathways, whether in a vertical program as occurs in Barbados or whether integrated into the wider NCD management has occurred in other parts of the region. This has been a priority and we can see the gains. So similarly, efforts to stop tuberculosis, so the Stop TB program, managing malaria, and even though that might not be the main vector-borne disease or mosquito-borne disease of concern in our region, we know that in Guyana, it still remains very relevant. So we need to, think about how do we optimize our travel health services within the region so that people know how to protect themselves when they go to malaria endemic regions. Then combating hepatitis, waterborne, and other communicable diseases. So again, we see how the interlinkage between health and, say, the other ministries, the other sectors, such as the ministry that provides the municipal water supply, the ministry that is responsible for solid waste management, for wastewater management. Because once we can ensure that the wastewater treatment is appropriate and that there's no contamination of our aquifers or surface waters, then, this reduces the likelihood of waterborne diseases. And hepatitis, this requires, so we have programs where hepatitis B has now been incorporated into the routine immunization program in many countries. So this again allows us to start to protect our young people at an earlier age. And there are other infectious diseases, but these are the main ones which fall under the SDGs, and addressing the social and behavioral determinants. What are the living factors? What are the educational factors that may inhibit people's ability to uptake the treatments that are offered or access to services that are available. And we need to also look at living conditions with respect to the interplay of TB and HIV/AIDS. So providing suitable housing solutions where there is a limit on overcrowding, not just providing medications for HIV or tuberculosis, but making sure that people's living conditions optimize their outcome, because we do know of the link between TB, tuberculosis, and HIV, particularly in settings where people live in overcrowded conditions. Now, the fourth picture I have here is someone asking a question, and you may ask yourself, what are these neglected tropical diseases? And some of them are not that far-fetched for us, because the list actually includes dengue fever, which we know in our region is a very important cause of morbidity and in some cases mortality. And if we look at the diagram on the left, you know, the deeper the pink, the more number of neglected diseases are present. So if we look at the box, it shows that the Caribbean is primarily pink, except for Haiti. But the thing is, it doesn't mean that we should neglect or become complacent. So a lot of effort has been made by our governments across the region in ensuring that we rely on environmental management to, you know, remove the breeding sites for dengue fever. There's the fogging, but there's also involving the public, you know, public education is very important for us to achieve this SDG goal target, because we really want people to understand the link between their activities and providing breeding habitats for the Aedes aegypti, which causes dengue fever. And the Aedes aegypti, people recognize that that has become a domesticated mosquito. So our actions at the individual level within households can actually provide, you know, perfect conditions for Aedes aegypti breeding. So this becomes very important, and it requires multi-sectoral collaboration, because working with the Sanitation Service Authority, solid waste management is important. So target 3.4 NCDs, we know that NCDs are a big problem in our region, and the whole idea is that we need to look at it from a very comprehensive approach, including mental health, because often mental health has been parked by itself, but truly mental health is relevant. It is something that needs to be thought of as an integrated part of NCD management. And I do agree with the statement that there's no health without mental health, because how do we optimize our resources for living if our mental capacities are affected? And if we look at a few figures, we see that there are more than 43 million NCD deaths across the world, and a lot of them are premature deaths. But if we drill down to the region actually has 4 times the rate of premature deaths compared to the other countries. So the region, as in the CARICOM area, if we look at ourselves with respect to the region of the Americas, we actually have 4 times the likelihood of deaths, premature deaths from NCDs. So again, it comes back to how do we build capacity and resilience within our healthcare systems to prevent, to educate our population, but also how do we work with the social determinants of health, the commercial determinants of health, to provide better food, to have better food security. Mental health is important. Many people know that suicide has become, you know, more has been brought more to focus because we're more comfortable speaking about it. We do have some countries in the region where suicide levels are quite high. And it is known that globally, lower and middle income countries tend to have 70% of the suicides that have been documented. So regional disparities do exist, and COVID-19, because of the lockdowns, because of some of the things that restricted our cultural expressions, we noticed that there was a increase in, you know, the mental health presentations within the system, and particularly for young people. Climate change, loss of lives and livelihoods, that has a mental health overlay as well. So we can see why these are important, and we can look at some of the factors that have been the strategies rather that have been rolled out in countries. So in Barbados, there's a mental health hotline across the region. There's been strengthening of mental health delivery training of people working with Pan American Health Organization. So it is important. And for us to achieve SDGs, we have to get political will. We need to have health in all policies. So it's not just the role of the Ministry of Health or the NGO health sector, but all ministries. We need built environments for people to walk if we want them to exercise and help improve their NCDs, if we want people to eat fresh fruits, we need to be able to support agriculture and really promote food security. Sustainable financing, that was mentioned by Dr. Maharaj. We need to look at how we can improve our financing for the health system and to keep it sustainable. And what are some of the opportunities? Really, we can look at, improving our coverage of services and making access easier, whether it's through time, whether it's through geographical location, whether it's language, because we do have a lot of movement within the region, and sometimes language and culture actually acts as the barrier for universal health coverage to be actually realized by people. And then interdisciplinary approaches, we want to do more research. We want to get SDGs embedded in our curricula in medical school, nursing school, pharmacies, and financing. So across the various disciplines and also within workplace policies, because an all society approach is really the only way that we will be able to optimize our ability to achieve the SDGs. So I hope this has caught your attention. I hope it's underscored the interrelatedness of these different targets, but also how SDG 3 is related to many of the other SDGs and some of the aspirations that we have for ourselves as people in the region. So I thank you, and I will turn over to Dr. Pilgrim. Thank you so much.
Thank you so much. I think we should give our presenters a round of applause. Dr. Maharaj and Dr. Harewood have done an excellent job of helping us to understand how the SDGs interact, and especially SDG number 3. So, ladies and gents, I offer you the opportunity now to ask any questions you might have of our presenters. And I'm hoping that there are some questions. No questions so far. All right, well, I have a couple of questions. Dr. Maharaj, you made a very critical statement on how you defined health, and I'd like you to define it once more because I think that will be a critical point for us because we just think, and I think Dr. Harewood referred to this as well. So can you use your definition for us one more time?
It,
The
that
equity,
healthcare, pardon?
the one on equity, etc., justice.
Oh, yes, no. So healthcare basically, at the end of the day, is the presence of justice, equity, and resilience. And I don't know if many of you guys have ever seen the equity. What does equity mean? And justice. There's a beautiful picture that depicts this. And if you give me two seconds, I will pull this picture up, you know, because it always tells you what is the difference between equity, justice, and reality and liberation, right? And if I can share my screen, hopefully.
Yes, you can.
Right, lovely. And I will be sharing it now. 1 second. I don't know what is happening. Sorry about this.
No problem. If
Yeah,
you
yeah,
want us
yeah.
to give you a minute and ask another question, you can just let me know. We can do that.
We should be good to go.
Okay, great.
Right, good. And yeah, I mean, I always do this with my first year students. This is always a very important bit there for me. You know, equity is everybody's equality, standing up on the same box,
Yeah.
right? To
Can you
see,
do it presenter mode for us? It would be
let me
large
do presenter mode and see if that works. Slideshow,
time slot, right? And just
right?
right.
From current slide. Yep. So if you look at it here, equality is what many times we talk about. We give everybody the same size of box to stand on. That is equality, right? Equity is when we give people what they need to see over the fence, to take into consideration their situation. Reality sometimes, right, is this: the guy that needs the most actually gets buried in the ground, and the guy who doesn't need much actually gets a better seat in the stand. And liberation, or what we call justice, sometimes justice is used, is when, and this is the difference between equity and justice as well in healthcare, that everybody gets onto the field. and everybody's able to play and everybody's able to have that fair view of what health is. So, many times this is what is given equality in our healthcare systems. The rich, the poor, the realities and situations are not taken into consideration. But not until we get equity and what we call justice, then we will be able to make some real changes in that healthcare system. And that's what Dr. Harewood was speaking about when she spoke on the social determinants of health,
Hmm.
right? Social determinants of health really speaks to the fact that we need to take persons' circumstances into consideration to ensure that their health needs are best met. It does not mean only to create a field, right? If you do create the field in a place that people don't have access to it due to crime, due to transportation costs, it is even a useless intervention at that point in time. So, you really need in healthcare to look at, and many people forget the word care. When people come to a health system, the most important thing is that they require care. They don't want to be there. They actually wish they can be somewhere else. And many times we forget that and we just deal with it in a transactional manner. And that is where we have to remove that transaction out of it. That is what equity means, moving it from being a transaction to actually being a caring system. And that is how we are able to move to make a better system at the end of the day that meets the need with equity. And hopefully, we create justice. So, equity is for the patient, justice is for the family, whereby we are able to remove all of those other barriers that would have made the social, as you call it, I'm trying to get back the word, but the social determinants of health easier, put it in a better place for the family. That is what you want. You want a better place for the family to create justice for them at the end of the day. Sorry about that, and sorry for the delay.
No, not a problem at all. Thank you so much. Dr. Harewood, would you like to comment on that before I go on to my next question?
Well, I would just say support what was said in terms of even how so I think part of the purpose of this webinar is really to inspire, aspiring students or people who are currently in the field to rethink how services are offered and to recognize that we're in such a dynamic situation in terms of climate change that the things that define vulnerabilities or that make people become more in need are rapidly changing. So I would have mentioned language barriers because, we often think about, people leaving maybe the African subcontinent and going to Europe or wherever else. But even within the region, we've had movement of people from South America within into the Caribbean, and people come from Haiti and go to other places. So, we do have things that may make it a bit difficult for us if we do not have that equity lens. So what is it that you specifically need? And if you want to break down equity more, as I normally would say to the students, there's the whole concept of vertical equity and horizontal equity. So vertical equity is really what we are touting today, where the needs are different. So what you give to people need to match the differential needs and not just a blanket thing for everybody. And really, I think the SDGs, will not be working. And I think that underpin the whole idea of the SDGs, really and truly, to address the conditions in which people live and work as well as we try to optimize health and to achieve the other SDGs. So I do support that should be a continuous focus for us. Equity, justice, and helping people to, actualize their human rights, the rights that you're born with as a human being. And that's the only way we'll be able to do it.
All right. Thank you so much, Dr. Harewood. We do have a question from the floor. It's from Crystal Rahman. Go ahead, Crystal, please.
Hi, good afternoon. So basically, I'm affiliated with a all-female organization that has UN status, and I'm very familiar with the SDGs. Today's session has been very enlightening, and I'm just wondering, based from the top of your heads, if what initiatives or that as an organization that we could probably get involved to help some of these issues. Um, You spoke about with regards to the pregnancy health, and my mind already started racing on different things that we could probably do as an organization. But since you all are the experts, maybe you all may have additional ideas that you can share.
So I'll give some examples. Actually, I won't go to ideas because I like practicality, how things happen practically. In Trinidad and Tobago, there's something called the JBF Foundation that was born, is an NGO, not a NPO, but that was born out of someone losing their child due to cancer. But what the JBF has done, they have partnered with the public health system, and if a child has to get radiation therapy or any sort of therapy, they have made that process a very seamless and caring one for the family. And they do it by raising funds, etc., and bringing awareness to corporate Trinidad and elsewhere on why it is so important for this sort of intervention. It's a real tangible way with effort that they have just, I'm just using one instance, right? One disease, and it can be done for many others, right? Has gone in and is making a very tangible difference in management because we spoke, I think both, I spoke to some extent, but I heard it very much from Dr. Harewood concerning financial sustainability. The realities are many of these health systems cannot on their own have the levels of revenue to deal with it. Between 8% to 5% GDP is spent in the Caribbean versus the global norm, which is about 9, right? So there are constraints, and these are some tangible areas in which you can make this happen. I will also explain to you many of times when health professionals have waiting times in free healthcare systems, many people don't understand. It's simple things that keep these things back: beds, consumables. These are the issues that they face on a day-to-day basis. So, tangible interventions by NGOs. It's very nice when they spend a lot of money on prevention because it's a critical area. But there's also some other areas in which you can make a real difference by just working. And the critical thing is speak not only to the healthcare managers, but speak to the front line. The front line will always give you where you can. I'm not on the front line now, but I'll tell you in other places when I'm on the front line, you speak to the frontline workers and they can give you a lot of solutions and you will have a major role to play. I have seen it been transformative. Sorry.
Thank you so much. Dr. Herwood, do you want to weigh in on that? Or
No, I agree that we need to interface. So, we kind of talk about everything, but again, how do things work? It has to be participatory. And you spoke with the frontline workers, but the other thing too is also going to the people who are the recipients of care to actually find out what is it that they need, because we might have our perspectives, but is it really matching the need? So there's the whole thing of express need, perceived need, and so forth. So I think improving our dialogue, because we're evolving, so we've got better in the region, but how to get a more patient-centered focus, but also for patients to understand that there's a responsibility that goes along with the rates as well, so that they can, sure, we can have more dialogue in, but I think there definitely is the role for the other organizations, NGOs, whichever, let's say civil society organizations, because if you look at some of the big initiatives, combating childhood obesity, even the mental health drives that are going across the region, they require input from people who have these skills. They're not government workers. They're doing it a lot of times on a volunteer basis. But again, public health, if it comes down to the definition of public health, it is really the collective actions of society. And that is something that we need to remember. And it's not just the experts. So we're all experts at our different levels, and we can all come to collectively to really, address some of these vexing problems, because it takes everybody, the commercial sector, the financial sector, etc., not just health. So health and all policies really will drive our success going forward.
Thank you so much. Well said to both of you. Are there any final questions? I have one question that I heard Dr. Harewood mention agriculture, and she was mentioning the fact that agriculture and food security are important to the healthcare system. Would you like to expound on that a little? Because that's going to touch on a few other of the SDGs that we have.
Yeah, so in brief, agriculture is important because, you know, if you think about it, nutrition really is what fuels us. But when we think about it in the terms of managing NCDs or even preventing NCDs, we're thinking about what is the quality of the food that we are ingesting. And part of the challenge within the region, maybe except for Guyana, we are net food importers. So it is often brought in more cheaply, but the problem is that a lot of it is ultra processed foods, which have been shown to be deleterious to health and actually make our NCD position worse. So how do we encourage the production of fresh fruits and vegetables? I mean, we do have, and I'm putting this in all the context, climate really does give us a bit of a challenge because as Dr. Maharaj says, when it's wet. When it is dry, it is dry. So it requires us to think through novel ways or innovative ways to get our farming done. So we do more roots and tubers, which tend to be more resilient to changes in climate. Do we look at greenhousing? How then do governments help support farmers in looking at new technologies, how to get away from the pesticide use? Because, climate change drives pest proliferation and more pesticides, the ground is depleted. So it's like a vicious cycle that can be set up. And the thing is, we need to be able to have some sort of idea where we can protect our farmers as well, because in some territories, predator larceny is another big issue. So if you agriculture could be an entire webinar, but the point is, if we can't, support what we're doing by providing the 5 servings of fresh fruits and vegetables that we tell people that they should eat, then we can see how it makes it difficult to actually have balanced nutrition, and it has implications for preventative measures, but also for people who are managing NCDs and just enjoying the fruits of the land, which we, as a rate, as human beings, we should be able to do. So I think there is a good scope for us to delve deeper into agriculture and health.
Thank you. Final comments, Dr. Maharaj? Oh, you're good.
First of all, I would like to thank the team for putting this together and allowing this. Health is your wealth. And the most important thing is that it is impacted by every aspect, as Dr. Harewood has said, of your life. And at the end of the day, most important thing is, which I'm inculcating now, health is the family's business. So put health at the top of the priority with your family, because it is what will determine your sustainability in the long term, both as nations, countries, as well as units. Take care. Thanks.
Thank you so much. Many thanks to Dr. Maharaj and Dr. Harewood. You guys have given us a lot to think about and have made some excellent connections. So I would like to thank you. I'm going to close the session just by showing you one slide on this, because this presentation has been brought to you by the ISDJ, and I would just like to encourage you to check out the ISDJ's website and their courses, because we are looking at courses which focus on the SDGs. Thank you so much. We are at 1 o'clock. I appreciate everyone who came, and I wish you all a pleasant rest of your afternoon. Have a great day. Bye-bye.